forum today. To initiate our program, we welcome Dr. Ganesh Swamy. His talk will delve into the most current understanding of how common spinal disorders develop and the research gaps yet to be filled. Dr. Swamy is a clinical assistant professor at the University of Calgary in the Cummings School of Medicine, as well as an orthopedic spine surgeon. His research focuses on sciatica pain caused by disc herniations and aims to help better identify patients who may require future surgical intervention. Ladies and gentlemen, please welcome Dr. Ganesh Swamy as he shares his research.
Good morning. My road to spine was a crooked one. I've always wanted to be an orthopedic surgeon and thought that I could help arthritic patients with their troubled arthritic joints. Joint replacements are some of the most powerful and cost-effective surgeries in all of medicine. I would have never considered spine at that time. It seemed too complicated, and the treatments didn't seem elegant. Unfortunately, in my last year of orthopedic training, I met a wonderful spine surgeon named Garth Johnson. He was a skilled surgeon, an amazing teacher, and had the power to make everything seem exciting. And he convinced me that much about spinal disorders remained unexplored. I could see also that treatment was changing and that there was many new technologies on the horizon that would make treatment better. I also was hooked. I knew spinal disorders are important and wanted to make a difference. We know the prevalence of spinal disease is tremendous, so let's have a little poll. How many of you have had back pain? Maybe raise your hands. Oh, that's tremendous. How about neck pain? Oof. And what about sciatica? My goodness. Fortunately, most of these problems in this room have likely been transient, but for many others, spinal disease are long-lasting and disabling. Spinal disease accounts for the most years lived with disability and is the 6th highest condition in terms of disability-adjusted life years world over. We've made very little progress in the past 20 years to improve this terrible statistic. Spinal disease has a point prevalence of about 10%, in contrast with 4% for osteoarthritis of the knee and 1% for hip osteoarthritis. I, and others, think that the intervertebral disc is the most important source of spinal disease. It's an amazing organ that sits between the vertebrae. It has no blood supply and is in an acidic and hypoxic environment, which generally we associate with death. The disc provides for tremendous motion, allowing all of us to pursue our daily activities, and like in the images on the right, allowing contortionists to perform crazy back bends. It is also under tremendous pressures. At rest, the pressure in your disc in L4-5 are roughly the same as an 18-wheel truck tire. When you bend over and pick up a modest weight, the pressures can quadruple, so 4 times an 18-wheel truck tire. As amazing as the spine is structurally, there is a problem. Evolution, or the creator, or whatever is your belief, led to an important design flaw. Our spines are meant to fail. As a result, there's a tremendous breadth of spinal conditions, all caused by different types of degenerative disc problems or spinal failure, and we call these conditions common degenerative spinal disorders. Our challenge is to identify the structural and biological reasons that this happens and that lead to pain and disability. For the most part, we don't know. Today, we'll talk about a few specific disorders that we've chosen to investigate further. And by the way, these drawings are from one of our graduate students, Valerie Cates, who is not just an amazing artist, but is studying how to better communication with patients about spinal surgeries. We'll first talk about intervertebral disc herniations. Here, a piece of disc cleaves off, departs from its home, and ends up in the spinal canal. This pushes directly on spinal nerves and causes tremendous inflammation, and the end result is sciatica, a screaming leg pain. It was in the 1930s that we first recognized this problem for what it is. Doctors Mixter and Barr from Harvard University published a paper suggesting that disc herniations were not tumors, as was previously thought, but more likely ruptures of the intervertebral disc. We now know that after the disc herniates, 85% of people improve spontaneously. The disc herniation in most people gradually becomes smaller. It doesn't go back into its original home. Moreover, the herniated piece becomes resorbed, or it dissolves. We think that the immune system is which usually functions to fight infections, is the dominant player. The problem is that when you herniate a disc, you don't know if you're going to be part of the 85% who will improve spontaneously, and we'll call this group resorbers, or if you'll be part of the 15% that need an operation after 3 months of waiting, and we'll call them non-resorbers. We thought that if we could distinguish between the two groups, we could then figure out what specific biological mechanisms are in play. And since the immune system is involved, we thought we'd look at the inflammatory system, specifically in the blood. So our first plan was to measure 48 proteins at a time and look for patterns of inflammation. Others in the Institute had done it for different types of arthritis. We then met an Institute member, Antoine, or Tony Dufour, who is a guru of proteomics. Proteomics is a science of measuring many different proteins at once with great accuracy. He introduced us to a few companies that could make tests in which you can measure 7,500 or even up to 10,000 proteins with great accuracy in a single vial of blood. More, we figured, is better. So we decided to use these high-tech assays. The next hurdle was to get patients. Before we set up the sciatica clinic, obtaining treatment with proper knowledge was very difficult. Patients would present themselves to the emergency department, or the family doctor, or the chiropractor, or the physiotherapist with this severe pain. While there are some loose guidelines for care, there are certainly no clear treatment protocols for this problem, with a lot of diagnostic uncertainty early on, all making for confusion, treatment delays, and missed opportunities. So we set up a clinic to see these patients early. Our clinic started small during the COVID pandemic. We'd get a few referrals a week, then a half dozen, and now 10 or more patients a week. It feels like an indispensable service. We evaluate patients, offer a clear clinical diagnosis without the need for an MRI, and optimize non-surgical care. And the approach has really worked. We offer a service that helps patients get better faster and almost with no additional resources to the healthcare system. And interestingly, as had been predicted, 85% of patients are resorbers and got better with medical care alone, and 15% need surgical care. We've accelerated the whole process mostly to the benefit of patients. So back to the science. With enough patients recruited, we sent off the blood samples and received massive amounts of data. The data are in a huge spreadsheet, 7,500 columns and many rows. And to analyze this data is a big challenge, so we employed machine learning protocols. Now, machine learning sounds fancy, but at its root, it's mathematical detection of patterns. We partnered with ML experts at the university, and to our surprise, we could identify a collection of 30 or 40 proteins that could predict whether you would be a resorber or a non-resorber. At first, we weren't sure the data were correct, sent off more samples to double check, and these differences have persisted. We don't necessarily understand what these proteins mean, but put together, they may be able to predict whether you'd be a resorber or non-resorber when you walk through the door with sciatica. We're pretty excited about this and planning to replicate and confirm the findings at bigger scale. We also want to figure out why the two groups are different so that we can eventually understand the mechanisms and design targeted treatments. If you could predict the course of your sciatica, it would be a huge change in the course of treatment. Non-resorbers could have surgery early. Resorbers could be reassured that their suffering is finite and wouldn't have to run around seeking other answers. In all, accurate predictions of sciatica is our goal. While we work with sciatica in the lab, we also work on other common spinal disorders. One such condition is degenerative scoliosis. Patients with degenerative scoliosis are amongst the most disabled in all of medicine. They can't sit for long. They can't stand for long. They have terrible back and leg pain. And for reasons that are yet unknown, 85% of these patients are women. And most of these women are postmenopausal. Leveraging the close collaborations between the surgeons at this institution and the Institute, we have developed an intervertebral disc tissue bank with now over 200 samples of excised disc that we take during surgery. We think that the discs in degenerative scoliosis are soft and become increasingly soft with age and possibly with menopause. To do this work, we need a multidisciplinary team of scientists, students, and engineers. We have a lot of experiments planned in this realm. We want to understand why these discs are different and why this happens mainly in women. Stay tuned. A last type of investigation in our lab I'll talk to you about today is cervical disc degeneration. We're working on understanding the motion of cervical vertebrae in great detail with a cutting-edge technology. Dual fluoroscopy can, with an accuracy of about 1 millimeter and a degree, show us how bones move in three-dimensional space. We can then use this technology to understand how cervical spines move with degeneration and cause pain, and how disc replacements could work or how they could fail. As you can gather, we have lots of work to do. We integrate lots of technologies and experts to study common spinal disorders. We've been training lots of students who learn about spinal disorders and do all the work that we've been chatting about today. Some of these young people will become investigators themselves and discover new findings. Some of them may find new treatments, like building disc replacements that really work. Overall, we seek to build an ecosystem of excellence around spinal disorders. Now, we're lucky not only to have the personnel, expertise, and facilities, but we're also lucky that we have very generous, amazing philanthropic funding. My wife and I are good friends with Sam Shaknowich and his late wife, Geraldine. The topics of conversation were generally dogs and hockey. Out of the blue one day, Sam asked me what we did in the lab. And after a brief explanation, he asked, "Do we need more money?" I, of course, said yes. With a generous gift, they have established the Mrs. Geraldine and Dr. Sam Shaknowich Chair of Spinal Research. They have also pledged an even larger gift, which will fuel many years of future high-quality spinal research. We're really grateful to Sam and Jerry. Their gift will keep us on the frontier of spinal research for many, many years. In closing, the understanding of spinal diseases is in its very early days. We've made very little progress, unfortunately, in decreasing spine-related disability. But with clear focus and lots of energy, I hope that we can. Thank you.
Thank you, Dr. Swamy, for sharing your important and very hopeful research. Thank you.